Welcome to Motivational Interviewing, Enhancing Motivation to Change Strategies. The goals for this session are listed on the slide. As you can see, we are going to look more closely at the change process, readiness to change, and motivational interviewing tools that are commonly used in the brief intervention. As you use motivational interviewing, or MI, with patients, you will likely find that they are in various states of readiness to change: pre-contemplation, contemplation, preparation, action, and maintenance. In the pre-contemplation stage, the patient doesn't feel there is a problem and therefore doesn't think they need to change. In turn, the goal is to build a trusting relationship and raise awareness. Our tasks are to engage, inform, encourage, explore, and acknowledge lack of readiness. In the contemplation stage, the patient sees the possibility of change, but is ambivalent and uncertain about beginning the process. So the goal is to build motivation and confidence. Our tasks are to explore and resolve ambivalence and evaluate pros and cons. In the preparation stage, the patient begins making a plan to change and sets gradual goals. So the goal is to negotiate a plan. Our task is to facilitate decision-making. The action stage occurs when the patient begins to implement specific action steps and behavioral changes. Our goal at this point is to support the plan and action steps and help think through possible needs for support. Our main task is to support the patient's confidence and self-efficacy. In the maintenance stage, the patient continues to sustain desirable actions or repeats periodic recommended steps. In turn, our goal is to help the patient maintain the change or the new status quo. Here, we are mostly thinking about early changes that may signal relapse to unhealthy behaviors or return of symptoms. Having a prevention plan often helps people think about slippage. For example, gaining more than 3 pounds may be a target in weight management. In depression treatment, failure to attend certain usual activities may signal increasing anhedonia. It all depends on the person and the problem. Events, internal or external, can trigger an individual's return to previous behaviors and the need to cycle through the process again. Patients may have had unrealistic goals, used ineffective strategies, or put themselves in environments not conducive to successful change. The inability to sustain changes feels demoralizing to the person and creates the feeling that it's too hard or not really worth the effort. However, expressions of frustration or indifference don't necessarily mean a patient has abandoned their commitment to change. Helping the person examine how the slippage occurred, what got in the way, can help move the person back into action. It is crucial to remember that a patient's readiness to change is a state of mind, not a trait. Readiness to change is fluid, meaning it will change based on the person's experiences. Change talk is at the heart of MI. As the amount of the patient's change talk increases, so does their commitment to change. Through our conversations, we can evoke and affirm desire, ability, reasons, and need. To remember those, use the acronym DARN. Change talk occurs when the patient expresses some level of motivation to change. The A from ORS, affirmation, is critical. Gently reflect and summarize consequences of the behavior, focusing on those that have been identified by the patient. The MI strategies that are most commonly used in the brief intervention are listed on the slide. Let's take a look at the decisional balance first. The decisional balance is a model that helps explain behavior change. The point is to help the person look at factors that may support staying the same versus changing a behavior. In some ways, it's a cost versus benefit assessment based on the person's concerns that aims to leverage benefits of change against the status quo. When conducting a decisional balance discussion, accept all answers given by the patient. Avoid the urge to disagree or argue with their views. Instead, explore them. Be sure to note both the benefits and costs of current behavior and of change. This exploration should include your patient's goals and values. What is important to them? The second MI strategy in the brief intervention is the readiness ruler. Readiness rulers can measure three things: importance, or the priority to change, confidence in one's own ability to change, and readiness, which is a willingness to change. Here's how to use the readiness ruler. Show the patient the readiness ruler and ask, on a scale of 1 to 10, how ready are you to make a change? If the patient answers with 5, the follow-up question would be, that's great, you're 50% there. So, why are you a 5 and not a 3? The strategy of the readiness ruler may seem counterintuitive. If the patient says, I am at a 5, rather than asking why not a higher number, you should respond with affirmation. For example, great, it sounds like you're 50% of the way there. Asking the patient why the number is not lower invites him or her to articulate reasons and motives for considering change. If you ask why the number is not higher, it elicits barriers and reasons for staying the same. In effect, it showcases resistance talk rather than change talk. Before we move on to talk about personalized reflective discussions, let's take a minute to summarize. Motivational interviewing principles, steps, and strategies are the foundation of brief interventions to help patients make changes toward healthier lifestyles. The third MI strategy that is critical to the brief intervention is personalized reflective discussion. In this context, we use selected health information to talk with our patient about the identified concern. For example, assessment information related to increasing weight, coupled with increased pain levels, activity intolerance, and depressive symptoms, might guide a discussion of weight loss using the brief intervention. The point is to use MI strategies to facilitate a personalized, reflective discussion that increases the person's readiness and commitment to change. There are 5 steps in the personalized reflective discussion, beginning with initiating a reflective discussion. Reflective discussion between a clinician and patient usually follows other conversation. As noted earlier, relationship and rapport with the person is critical. The first step is for the clinician to ask for the person's permission to have the conversation. Asking permission shows respect for the person's autonomy. After being invited to discuss findings, the clinician can review the results of related health assessment data. The example shown on this slide is for the Alcohol Use Disorder Identification Test, or AUDIT, a screening tool for alcohol use. To evoke personal meaning from your patient, use open-ended and evocative questions. This will give you a better understanding of how the patient views his or her health and behavior. These questions are examples of those you might ask after reviewing the audit results with your patient. As in ORS, summarizing the discussion provides a good way to reinforce the concerns shared and pave the way for change. Using the readiness ruler after the personalized reflective discussion and summary may further enhance a patient's motivation to change. Remember, as a clinician, you will decide how to best address the issues with each individual patient. The information here is just a guide. A plan does not need to be overly complicated, but should be both realistic and specific, and one the patient is willing and able to follow. Making a plan is really just the first step. Following up to check on the person's progress is essential. In many situations, a review at 4 weeks, or sooner depending on the problem and related risks, is critical to see how the plan is working for the patient. In the next part of the program, we will identify the steps involved in the brief intervention. You will also have the opportunity to practice the brief intervention using role-playing. Thanks to our funding agency for supporting this program.